to delegates, when can we start off?
Sir, at 7 o'clock we shall start off.
Yes, yes.
Okay,
Agreed.
sir. Then I will
Agreed.
be handing over to you, right, sir?
Agreed. Yes. Yes.
Yes.
That's
Thank you.
that's how it works. Yes.
Thank you,
And
sir.
by sharper closer to 8 o'clock, we'll try to close. Huh?
Sure, sir. It's not an issue. Thank you.
Okay. Okay. Wonderful. Thank you. Thanks, Dr. Gupta. So, Dr. Megha and Dr. Shilpa, you might have to gently tweak your running of the session.
Yes,
Huh?
it get over sooner than planned.
Yeah, that is still okay. That's still okay. See, I'll tell you, as I mentioned, this is a repository of relevant talks. So it goes into a permanent system. So it's an extremely relevant session anyhow.
Yeah.
Anybody can access at any time. So
Oh.
clarity, relevance, and the material remains forever. So for meaning until of course the next level of neuropathology happens.
Next WHO.
Yeah, exactly. Dr. Shilpa, your camera is not properly placed. And just ensure that it's because you'll be on. You'll be you'll be in the inset, isn't it? Okay. I think sharp 7 o'clock will start. Ms. Rituparna?
Yes, sir.
Sharp 7 o'clock will start anyway.
Yes.
Is it
sir.
okay?
Yes,
Sounds
sir.
okay?
Okay, sir.
Yeah, wonderful.
I think Dr. Naveen has logged out.
Yeah, he will join. I'll just check with him. I mean, just a question mark. I'm just mute.
So, sir, with all your permission, we are starting with the session now.
Yeah.
So may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good evening and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as a digital partner for this online event hosted by the Indian Society of Paediatric Neurosurgery. And the focus of today's session is Paediatric Gliomas. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Suhas Udayakumaran Sir, the Honorable Secretary of ISPN, to start the event today with his enlightening words and for the further coordination. So that is all yours, sir. Please proceed.
Thank you, Rituparna. Thank you. So for all the delegates and all the residents and the trainees who have joined us, thank you for joining. And as you know, this is a part of our industry endeavor to create awareness of topics relevant to pediatric neurosurgery amongst you all residents. So today we have chosen that one of the primary topics of neuro-oncology, and that is the neuropathology aspect of neuro-oncology. And today's talk is going to be on pediatric gliomas. For next two subsequent sessions are going to be based on neuropathology. And today's session is going to be dealt by Dr. Shilpa. Dr. Shilpa Rao is an associate professor at Nimhans at Bengaluru. And we are associated along with that, we have a second faculty from NIMS Neuropathology Department, Dr. Megha Upin, who is a professor at additional professor at NIMS Hyderabad. So together, the next two sessions of this session and the next session in the April would be conducted by them to complete or at least give you an overview of neuropathology. You all should agree that neuropathology is having a grand change in terms of the nomenclature and the molecular diagnostics, and it's an absolutely relevant topic to start off with. Thank you all for joining, and I'll hand over the system to Dr. Shilpa. Dr. Shilpa,
yeah, thank you, sir. So we'll start. I'll just share my screen and let me know if it is visible.
Yes.
Okay.
Thank you, Shilpa. Thank you.
So good evening, all the residents and delegates who have joined the session. We are going to be talking on discussing on pediatric gliomas, very basic concept based on the WHO CNS5 classification, which is the most recent classification and which we are all following. It was released in the year 2021. So you know that gliomas as such can be at a radiological level, intraoperatively, and even at a pathological level, can be either diffusely infiltrative or circumscribed. All the diffuse gliomas were previously clubbed into a single group, whereas now the diffuse gliomas are separated as adult type and pediatric type. Why that categorization? Because it is now recognized that the pediatric type gliomas are distinct from adult type. You would have already known that they have different behavior clinically, and the important point to remember is pediatric type glioma doesn't mean that they occur only in pediatric age group. They can occur in slightly adolescent, young adult age group also. But why they are called as pediatric type is they are majorly concentrated in young pediatric children. But remember, adult type can occur in pediatric children, and pediatric type gliomas can occur in adult patients as well. So today we are going to be concentrating on this pediatric type, high grade as well as low grade gliomas. If you see this nice pictorial representation on the right, you can see that the adult type diffuse gliomas mostly are classified based on IDH mutation, 1p19q co-deletion, ATRX mutations, whereas your pediatric type diffuse gliomas have different mutations. They are concentrated with histone mutation and RAS-MAP kinase pathway alteration. That is the main reason why they are completely separated out into two different types of diffuse gliomas. Now, if we look at the low-grade gliomas versus high-grade glioma, on the left of the screen, you are seeing all the high-grade gliomas in pediatric type. On the right, you are seeing all the low-grade gliomas in the pediatric type. So on the left, don't go by the names. I will explain to you the names later. Just concentrate on what are the changes which are happening. You can see H3 here, H3 here, and H3 here. So H is for histone, which is an important alteration that occurs in almost majority of these pediatric type diffuse high-grade glioma. Whereas on the right-hand side, these are all the pediatric type low-grade glioma, diffuse low-grade gliomas. We're concentrating only on the diffuse low-grade gliomas here. So here there are different alterations, all of which belong to either RAS or the MAP kinase pathway. So the first important thing that you need to remember are that pediatric type diffuse gliomas can be high grade, can be low grade. The high grade gliomas are enriched in histone mutations, whereas the low grade glioma have all your MAP kinase pathway alteration. So in the pediatric type diffuse high grade glioma, let us start off with. Here you have another nice pictorial representation, which is showing that whatever is in yellow, all of them have K27M mutation. So these are the histone mutation. I told you H stands for histone. And all the midline gliomas, mostly occurring in the thalamus, brainstem, or the spinal cord, they have what is known as H3K27M mutation. Okay. When you come to the cerebral hemisphere, that is the non-midline diffuse hemispheric gliomas, you see they're all mostly blue or red. Blue standing for G34R or V mutation. Again, this is another histone mutation, which is H3G34RV, which is in the hemisphere. So in the midline, you have H3K27M. In the hemisphere, you have H3G34 mutation. IDH mutation, if you look at it in children, they're very rare. But as I said, in adolescent also, you can have IDH mutation. So if you have IDH mutation, it becomes an adult type diffuse glioma. It doesn't become a pediatric type diffuse glioma. But in pediatric age, less commonly, you can have IDH mutation also. That brings us to the third category, that is the H3 IDH wild type. So if both histone and IDH mutations are absent, that is getting grouped as H3 IDH wild type. The fourth group of pediatric type high-grade glioma is the infant type hemispheric glioma. Okay, but what is not included as a distinct type in the WHO classification is BRAF mutation, which is very important in pediatric age group, be it high grade or low grade. In all the pediatric age group tumors, it's important to test for BRAF mutation as well. I'll tell you why in the subsequent slides. Now, what is the significance clinically of histone mutation? We are talking so much about pediatric type high-grade gliomas concentrated or enriched with histone mutation. What is the significance? You can see here, depending on the type of mutation, the age is varied and also the survival. Most importantly, the survival varies. So on the left hand, if you see the median age for H3G34RB mutation is about 15 years. Whereas for K27M, you can see it's much below 10 years. That means in the midline gliomas are more concentrated in young children, whereas your hemispheric gliomas are more in adolescent age, and even they come up to the young adult age group as well. So even in young adult, that is in 20s, 30s, early 30s, you can see this pediatric type hemispheric glioma. Coming to the survival, the worst survival is for the H3K27M, that is a midline gliomas. G34R have an intermediate prognosis, whereas the wild type, depending on their further classification, do vary. Okay. So what is this histone we keep on talking about, around which all this classification is actually based on? So histone is nothing but these round proteins that you are seeing. These are the histones around which DNA will coil around. The function of histone is to keep it in a compact state. So there are different enzymes which are mentioned here. These enzymes help to keep it in a compact state, that is a chromatin. If it is in a compact state, there will be no transcription happening. If there is no transcription, there is no cell proliferation. So it is kept in a check. There is no unnecessary cell proliferation. Whereas if there is any alteration in this K27 that you're seeing at the tail of the histone, the chromatin opens up. Once it opens up, the transcription becomes active and you have lot of cell proliferation. So you have unwanted cell proliferation that leads to tumorigenesis. So the basic mechanism I have told you. The change from off to on state can happen via different mechanisms. One of them is mutation in this K27. That is a K27M mutation that we are talking about. There are other alterations as well. So all of them, what they cause is a universal reduction of what is called as H3K27ME3. So H3K27M is different from H3K27ME3. M stands for methionine, which is replacing lysine, whereas Me3 is a methylation, that is the trimethylated H3K27, which is normally present. K27M, that is a capital M, is abnormal, whereas Me3 is normal in a cell. Okay. So whenever there is some alteration, there is global reduction of this H3K27ME3. So what the current WHO has done is they have combined all these midline gliomas with different molecular alterations which cause reduction in H3K27ME3. So they are combined together as diffuse midline glioma H3K27 altered. Amongst that, we have the most common being H3K27M mutant tumor. Then you have the same diffuse midline glioma, but which does not show K27M, rather shows EZIP overexpression. The third one is EGFR mutant. So in K27 altered itself, you have three subtypes. The most common is H3K27M mutant. Then you have the EZIP overexpressed. Then you have the EGFR mutant. All of them, irrespective of their histological picture, will be a WHO grade 4 tumor. So that is how bad the prognosis is. Now I have a case example for you. This is a 26-year-old female. Again, telling you that pediatric type does not mean it is pediatric age group always. So this is a 26-year-old lady who presented with a very short history of sudden onset headache. And when she underwent imaging, I was hoping somebody from the audience would describe. Anyway, because of some technical issue, we will go ahead with slides. So you can see in the imaging, it is very clear in the T2 flare as well as the T2. You can see that there is a well or ill-defined lesion which is there in the thalamus. It is more on the right side when compared to the left. However, it looks very aggressive. It doesn't look like any low-grade glioma. So looking at the imaging itself, you would think of a high-grade glioma, which is located, of course, in the midline. Now, the surgical excision, what did it show? This is our routine H&D section. So what you can see, definitely there is increase in the cellularity. You can see the cells are showing some kind of nuclear atypia, but we are not seeing a grade 4 features. So for any grade 4, what we look at is necrosis, that is tissue death, and vascular proliferation, both of which are not there. However, the IHC that we have used here for this is, I told you, capitam means it is a mutant protein. It is positive in the tumor cells. All the brown indicates that the tumor cells are mutant. And in the center, what we have here is the ME3. So ME3, I told you, should be normally present. Whereas here you can see all the blue. Blue means there is no staining with the antibody. So you are looking at blue staining. That means there is loss of ME3. So there is loss of ME3 and there is K27M positivity, indicating that this is a diffuse midline glioma, which is H3K27M mutant, which is a CNS WHO grade 4, even though we are not seeing features of grade 4 on histology. So in 2016 itself, this tumor type was recognized. And it was defined as a CNS WHO grade 4 tumor, which can involve thalamus, brainstem, spinal cord with a very poor prognosis. One very important point to note here is, before we call anything as diffuse midline glioma, we should be very sure that it is a diffusely infiltrating tumor. It should involve the midline, because the H3K27M mutation, though not very common, can be seen in other tumors. Even in pilocytic astrocytomas, people have described H3K27M mutation. We ourselves have seen. So it is very important that we make sure first that it is none of those circumscribed, not ependymoma, not ganglioglioma. It is a pakka diffuse infiltrating tumor, okay, and located in the midline. So that was the most common type of diffuse midline glioma that we come. However, less commonly, we also see tumors in the midline which are not showing H3K27M mutation. Rather, they show EZIP overexpression. As you can see here, EZIP is present in the tumor cells, whereas M is negative and ME3 is lost. So universally in all of these, ME3 will be lost. So this is a diffuse midline glioma with EZIP overexpression. This is from the net. Again, you have a thalamic tumor, but which is more or less bilaterally symmetrical. And this is the third subtype of diffuse midline glioma, which is EGFR mutant. This is from a publication, not our own case. So you can see here there is a bilateral, almost symmetric, but more on the right side again. But here, unlike the first case that I showed, H3K27M you are seeing is negative. There is no mutation. Rather, this case had EGFR mutation. So that is the third type or the subtype of diffuse midline glioma, which is H3K27 altered. All of them are grade 4 and they all have dismal prognosis. So we have looked at the diffuse pediatric type midline glioma. Now we'll move on to diffuse pediatric type hemispheric glioma. So I've taken an example of hemispheric glioma here. This is pre-op. This is at recurrence. You can see still there is a large tumor with lot of edema around. It is almost involving the entire hemisphere except sparing the posterior part. So what do we see on histology? On histology, what we are seeing, they're highly undifferentiated cells. We can't even make out what is the cell type, whether they're astrocyte, oligocyte. Only thing is we have some fibrils in the background. We can say that it is probably glial. And all these that you are seeing slender channels, these are the blood vessels. So you have a high-grade tumor, highly vascular, undifferentiated. Now what IHCs we have done? To prove that it is glial, we always do two markers. One is GFAP, the other is OLIC2. So GFAP is nothing but glial fibrillary acidic protein. It will take up all the glial fibrils in the cytoplasm. But since the tumor itself is so undifferentiated, there are very few fibrils. You can see here hardly any fibrils. Most of the tumor cells are not showing any fibrils. But what is more important in this particular case is OLIC2. Almost all the diffuse gliomas, except a few, will show OLIC2 positivity. OLIC2 is a nuclear marker. Here, whatever we are seeing, these are the entrapped cells, but majority of the tumor cells are not positive. So it's a very important point that we should remember. The histone diffuse hemispheric glioma, that is the pediatric type diffuse hemispheric gliomas, are one exception to the rule that all diffuse gliomas are OLIC2 positive. Okay, this is one particular tumor which is OLIC2 negative. And like what we saw, H3K27M, we used the IHC. For H3G34B also we have an IHC. And you can see all these tumor cells have taken up H3G34B. As expected, the proliferation is very, very high. So again here, with or without microvascular proliferation or necrosis, this becomes a grade 4 tumor. Remember here, we have a V here. There is another protein, that is the R. So this is another case, again a diffuse hemispheric glioma. Here we have H3G34R. Both are combined into one tumor type, that is the diffuse hemispheric glioma, H3G34 mutant. More commonly, we get H3G34R. V is very, very rare. But you do have IHC antibodies which can be used for detecting H3G34R or V. When compared to the midline glioma, even though this is also a grade 4 tumor, they have an intermediate prognosis. If you remember the figure that I showed you earlier, H3G34 mutant tumors have an intermediate prognosis. They are more in adolescent and young adult group, whereas a midline are more in children, but it can always occur in adult as well. And this has an intermediate prognosis. So amongst the pediatric type diffuse high-grade gliomas, these are the two important groups that you need to know. One is the midline, which is H3K27M mutant, and the other, the hemispheric gliomas, which are H3G34 mutant. Okay. Other than these common ones, those tumors which do not show either IDH mutation or H3 mutation, they are combined as diffuse pediatric high-grade gliomas, IDH and H3 wild type. Further, based on more complicated techniques like methylation profiling, they have been divided into certain subclasses. However, it will be beyond the purview of this class. So we will not go into the details of what each class is. Just know that there is a wild type group. Then there is a special group which I mentioned to you earlier, which occurs in infancy. That is the infant type hemispheric glioma. The exact cutoff for this group of tumor is not yet established. Some follow 1, some follow less than 3 years. But essentially what it means is the most young children who have the hemispheric glioma, they have different molecular alterations compared to children who are, let's take between 3 and 10 years, where histone mutations are common, whereas in infant type hemispheric gliomas, you have rather different alterations. These alterations belong to ALK, NTRK, ROS, and MET. You can see here, if you see the hemispheric ALK, ROS, NTRK versus the hemispheric which show the MAP kinase alteration, The ones which show the MAP kinase alteration, they of course have much better prognosis. Whereas your RTK, that is the infant type hemispheric glioma, which is the red one, they have much worse prognosis. So again, indicating their clinical significance. Although the treatment as such may just be at a clinical trial phase, when the patient has these alterations, their prognosis is definitely different from the other tumors. So if you look at the 5-year overall survival, those which have ALK fusion will have about 53%. NTRK is slightly less. ROS is the worst with 25% 5-year overall survival. So that is the significance of identifying this group. Now, we have looked at the pediatric type diffuse high-grade gliomas, which are classified in the WHO. But whenever we find a pediatric or young adult patient, there is another test that we generally do. So here again, you have a hemispheric tumor, large hemispheric tumor in a 13-year-old patient. And on histology, what did we see? We saw again infiltrating tumor. You can see definitely there are a lot of these abnormal looking cells. They're darkly stained. There are some which have multiple nuclei. So when we did the usual stain, which I showed you, there is OLIG2 positivity, as I told you. OLIG2 is generally positive in all the diffuse gliomas, except your hemispheric histone HCG34 mutant. But interestingly, here you also have IDH mutation. So IDH is positive, ATRX is retained, and there is high proliferation. So what should we do next? It is a young patient, 13-year-old. IDH is positive. I think I should only answer the question. So generally when IDH is positive and ATRX is retained, we consider it to be an adult type and we go ahead with 1p19q because ATRX is retained. If ATRX is lost, then we take it as an astrocytoma. If ATRX is retained, then we have to do 1p19q to tell whether it is a oligodendroglioma or not. In this patient, we did 1p19q FISH and it was non-codiluted, telling us that it is not oligo. Of course, morphologically also it did not look like oligodendroglioma. So there is another important test that you need to do when you are looking at tumors, especially in younger patients, and when you see those giant cells. So these are the markers for mismatch repair. So you have a panel of 4, and you can see here that MLH1, MSH2, PMS2 are all retained, whereas you can see in MSH6, there is a loss of expression in the tumor cells. So this is a case of CNS high-grade glioma, which is associated with mismatch repair deficiency. These tumors can be IDH mutant or IDH wild type. So when it is associated with IDH mutation, this is a primary mismatch repair deficient IDH mutant astrocytoma. So it is also important to know that there is a mismatch repair deficiency. Why all this molecular? You see, pre-molecular era, everything had a same approach. Every patient, chemotherapy, radiation were the only hope after surgery. Even now, I am not saying that it has changed much, but we are moving towards a better option where you have targeted therapy available. I specifically mentioned a lot about BRAF mutation in the first few slides because there are a lot of targeted therapy which are available against BRAF mutation. Although it is not separately classified as a type of glioma, whenever there is a BRAF mutation, BRAF inhibitors can be used. And I think many people do call nowadays asking for BRAF mutation testing. I hope it is there in the clinics available for patients. So similarly, clinical trials are ongoing for the histone mutation. And last, we learned about the mismatch repair deficiency. Whenever there is a mismatch repair deficiency, a consideration for immune checkpoint inhibition can definitely be made. And we also saw the infant type hemispheric glioma where they have a lot of fusions. So under clinical trials are these drugs which target the specific fusions like lorlatinib for ALK and ROS, and there are several others which are being tried. So there is some hope only when we look at the pathogenesis of the molecular alterations which are underlying these diseases, we can offer treatment to these patients. So all these molecular alterations is towards a hope for better prognostication for these patients. So that was all about pediatric type diffuse high-grade glioma. Now we'll move on to pediatric type diffuse low-grade glioma. There are four types of pediatric type diffuse low-grade glioma. Diffuse astrocytoma MEB-1 altered, angiocentric glioma, polymorphous low-grade neuroepithelial tumor of the young, which is abbreviated as PLENTY. And the last one is diffuse low-grade glioma, MAP kinase pathway altered. So almost all the diffuse high-grade gliomas were grade 4, except infant type, which is not given a grade. Whereas here, if you see pediatric type diffuse low-grade glioma, all are grade 1, except the last one, which is not given a grade. So what is common to all these tumors is most often the presentation is they are epilepsy associated. And when we look at the histopathology of the slide under the microscope, generally we see oligodendroglea-like cells. By oligodendroglea-like cells, what we mean is the cells have a very clear cytoplasm. That is, around the nucleus, you see a clear halo. And as I'm showing you here, most of them are seen as WHO grade 1. Although they are grade 1, they are infiltrating tumors. Okay, they're not the circumscribed group of tumors. Amongst this, I will show you an example of PLENTY. The first and the last are pure molecular based diagnosis. So it is very, I would say, very less common. And what we generally diagnose, or most commonly that we have been seeing, is PLENTY. The next common one is angiocentric glioma. The other two are actually not very common. So let us first concentrate on a case of PLENTY. Again, a 13-year-old girl who presented with long-standing epilepsy. You can see here a solid cystic lesion, okay, in the temporal region. So what did the histopathology show us? Here in the H&E stain section, you can see relatively similar looking cells, almost all the cells, in contrast to what you saw in the high-grade gliomas that we were seeing till now. All were looking very angry. They had a dark chromatid. Whereas here you can see all of them have a round nucleus, some of them having this clear halo, what I was telling you. These are called as oligodendroglea-like cell. This is in one area of the tumor. But in other area, you can see again those pleomorphic looking cells, multinucleated, not really having the halo, some looking like astrocytes with fibrillary processes. So here you have oligodendroglea-like cells. Here you have astrocyte-like cells. You have pleomorphic cells. These bluish structures that you're seeing, these are calcification. And you have these red structures. These are blood vessels. So you have a lot of thin-walled blood vessels. Now, what is the IHC showing? So the typical picture, it's a young patient with long-standing epilepsy, has a medial temporal lobe lesion, which is solid cystic. On histology, we are seeing both oligo-like cells. We are seeing some astrocytic cells. Plus, OLIG2 is positive. Most importantly, you can see this is a stain called CD34. The tumor cells are all stained by CD34. This is a very important stain in this particular tumor. So you have CD34 being positive, BRAF V600E, which I already mentioned to you. A proportion of PLENTYs can have BRAF V600E mutation. However, this case is negative, but it is showing FGFR break apart. So this is another molecular alteration that can occur in PLENTYs. But you don't need to always do all these molecular alterations. The clinical picture, radiological picture with histology and CD34 coming positive and OLIG2 positive tumor more or less clinches the diagnosis. Being a WHO grade 1 tumor, you can see there is hardly any proliferation. In this entire area, we are seeing only one single soul expressing Ki67. So this is the WHO criteria for plenty. It's a newly described tumor type in the 2021 classification. The tumor has to have a diffuse growth pattern. It should have an oligodendroglioma-like component, which we saw. Because it's a low grade, only few mitotic figures. CD34 expression I showed you in the tumor cells, and it should be IDH wild type. Molecularly, you can have either BRAF mutation or FGFR fusions. Calcification also we saw, which is a desirable criteria, and absence of 1p19q codeletion because it has an oligo-like morphology. So it's a very classic picture even on histopathology. Okay, it is a grade 1 tumor. What is the significance of identifying it? We should not mistake it for an oligodendroglioma, which also has a diffuse growth pattern, which has oligodendroglial cells. But important to show it is IDH wild type and has CD34 expression. The other pediatric type low-grade gliomas I'm going to just touch upon because they are less common and generally not diagnosed on a day-to-day basis. So the diffuse astrocytoma MIB or MIBL1 altered is a diffusely infiltrating astrocytic tumor again. Does not have IDH or HT mutations, but as the name indicates, it should have MIB or MIBL1 alteration. So to identify this, we need to go for either NGS or go for specific fusion-specific probes. What you can see here, again, it is a very low-grade tumor with almost bland-looking cells. One important feature in this tumor is they do not express OLIG2. Okay, so I told you about the diffuse hemispheric glioma, H3G34 mutant, which do not express OLIG2. That is in the high-grade group. In the low-grade group, diffuse astrocytoma, MIBL1 altered, do not express OLIG2. There is another tumor which again does not express OLIG2. It is the angiocentric glioma. Okay, these three tumors are the exception to the OLIG2 rule. Angiocentric glioma is more easy to diagnose on histology because they have a specific pattern. They have a swirling pattern around the blood vessels. They are anchored to the blood vessels and they are positive for GFAP. Epithelial membrane antigen shows a dot positivity, as you can see here. Again, being a grade 1 tumor, it will have a low proliferation. The last tumor in this group is diffuse low-grade glioma, MAP kinase pathway altered. Again, it is a molecularly based diagnosis where we need to show any type of MAP kinase pathway alteration. They can have different morphology. They can look like oligodendrogliomas. I mean, they can have an oligodendroglide-like cell. They can have an astrocytic morphology. But one alteration that we can identify by it is BRAF V600E mutation. So what I want you to take the message from this is BRAF V600E mutation can be present in high-grade glioma. It can be present even in a low-grade glioma like this. So it is not going to upgrade the tumor unlike histone mutation. If you see histone mutation, it is definitely a grade 4 tumor. Whereas if you see BRAF mutation, it is not going to tell you that it is any specific grade of tumor. It can be seen across varying grades. So to summarize what we have seen, in pediatric type glioma, you can have the two groups, broad groups. That is the pediatric type diffuse high-grade glioma and pediatric type diffuse low-grade glioma. In pediatric type diffuse high-grade glioma, first is the diffuse hemispheric gliomas, which are H3G34 mutant, for which we can use two IHCs, that is H3G34R or B. Second group is in the midline, which is H3K27 altered. Most commonly, they have H3K27M mutation. Less commonly, EZIP overexpression or EGFR mutation. H3K27M and EZIP can be diagnosed on IHC. EGFR requires molecular testing. If they don't show histone or IDH mutation, then they become the IDH-H3 wild type group, which have further subclasses. Then a special group is the infant type hemispheric glioma, which show AL-cross or NTRK fusions. Significance is their survival is different and There are ongoing clinical trials against targeting these molecular alterations. So in this, the first two are by molecular alteration itself, they become CNS-WHO grade 4 tumors. If you look at pediatric type low-grade glioma, we first looked at the polymorphous low-grade neuroepithelial tumor of the young, also known as plenty. How do we diagnose? On histology is they are CD34 positive tumors. They can show BRAF mutation or FGFR alteration. Clinically, all these pediatric type diffuse low-grade gliomas are most often associated with long-standing epilepsy. MIB-1 altered and the MAP kinase pathway altered have to be tested for their specific molecular alteration. Angiocentric glioma is OLIC2 negative and EMA positive. Okay, so 3 OLIC2 negative tumors that we have looked at today are angiocentric glioma, diffuse astrocytoma, MIB-1 altered, and the H3G34 mutant diffuse hemispheric glioma. So I have some questions. I'll answer the questions also. For those who are seeing on the YouTube or wherever it is streaming, you can just see the questions and see the answers also. So in which WHO edition was the pediatric type glioma recognized as a distinct group of tumors? And no point in giving time. Okay, it is in the 2021 classification. Okay. So the second question is diffuse hemispheric gliomas of the pediatric type are characterized by mutations in. So it is the hemispheric glioma. So these are characterized by H3G34 mutation. The third question is diffuse midline glioma involves the following sites. Can involve any of these sites. Can it involve brainstem? Yes. Thalamus? Yes. Can it involve cervical cord? Yes. Frontal cortex, if it involves, we don't call it diffuse midline glioma because it is not in the midline. Fourth, what is the most economical way to detect histone mutations? It is by immunohistochemistry. I showed you a lot of IHC stains. Mismatch repair deficiency is associated with which of these syndromes? I told you about the mismatch repair deficiency syndrome. That is the CMMRD, which is constitutional mismatch repair deficiency. But there is another syndrome called as Lynch syndrome. So both of these can be associated with mismatch repair deficiency. Sixth question, diffuse midline glioma, H3K27 altered subtypes include all except. So it includes the H3K27M mutant glioma, it includes the EZIP overexpressed and the EGFR mutant. What is not included is the IDH mutant. So all the midline gliomas which are H3K27M altered are IDH wild type. Clinical presentation most common to the pediatric type diffuse low-grade glioma is long-term epilepsy, which is drug resistant. 80% of the plenties involve temporal lobe, like the case which I showed you also had involved the temporal lobe. So 80% of plenties involve temporal lobe. 20-year-old male presented with refractory epilepsy. On imaging, we saw a solid cystic tumor with minimal patchy enhancement. CT revealed calcification. So the preoperative diagnosis again would be plenty because of the age, the radiological findings. Most likely diagnosis is plenty amongst whatever options are provided to you. The last question, a molecular alteration in pediatric glioma against which targeted treatment is available. It is the BRAF mutation. Of course, now there are more targeted treatments being available. But BRAF mutation, which we can do at a IHC level and identify on the biopsy tissue that is provided, is BRAF mutation. So with that last question, I would like to stop sharing my screen. And if there are any questions on the chat, we can take.
Dr. Shilpa, thank you very much. It was an extensive and at the same time very simple. I can see a very good teachership in you. I mean, because as a neurosurgeon, I find all these topics very overwhelming, but at the same time, I had a clarity at the end of the talk. I think thank you very much for this extensive talk.
Thank you.
Of course, as I mentioned, to all those who are going to be around, who are listening, this talk is going to be there at the YouTube. So going through it again and again will make sense to have more clarity of the whole topic.
Sure.
And the questions, the MCQs at the end were very imperative and actually summarized your rest of the talk very clearly. Thank you very much for that.
Those who didn't have listened in the beginning also, at least they should take home some message.
Exactly. So there was a lot of clarity in at all levels. Thank you very much again.
Thank you.
I'm not sure we'll have questions because of the system issues.
Yeah.
But at the same time, I think we're good enough. We're good enough. We have covered the topic completely. I think Naveen, you want to Naveen?
Yeah. So as I'm there.
Yeah. You want to talk to her? Yeah, go ahead.
Thank you, Dr. Shilpa. I think you made a very complex topic very simple. It was very informative.
Yeah.
And I think we also got to know a few important things which we are always confusing to us. I think it will definitely help the residents. I think you prepared very well for the residents. It's really going to help them. Yeah.
It was an extremely good session, actually.
Thank you.
I think the residents should at least remember the terminologies. They will not remember everything.
Yes.
What they need to understand is now adult and the pediatric type are completely separated. What, as a pathologist, we need to know from you, the most important thing is what is the pattern of the tumor, because they are all divided into circumscribed and diffuse. So that information, I think the surgeon and the radiologist gives us. And then as the grade goes, the low grade are the indolent ones, the high grade ones are the more aggressive ones. And the high grade ones are the ones which are mediated by histone mutations. And the low grade ones we can still detect on morphology. And the most important thing is we are all able to categorize all these molecular types with the help of immunohistochemistry. We don't really need high throughput molecular studies in all of them. So it's important for the residents, and it is also important to know that they are pediatric type. We don't really call them as pediatric gliomas. So they are pediatric type and adult type. So they can occur vice versa in adults as well as the adult tumors in the pediatric age group. And the molecular classification is important as such to know the prognosis and of course to know the predictive effect of them on targeted treatments. I think
thank you. I had a few things to one is what you say as diffuse. Naveen, if you would agree that every time the radiology is not really diffuse, isn't it?
I do agree with that.
Like for a tumor for a tumor in plenty, most of them on radiology would look like a well delineated.
That's what I was just wondering. Why did you realize why was the term diffuse?
But on histology, when you see, they have at least in some areas you'll have them infiltrating. So most often we get confused with an oligodendrogloma. If there is not a very experienced or a person who has just started doing neuropathology, may confuse it for an oligodendrogloma.
Yes.
So, which totally changes the picture for the patient. From a patient's point of view,
Agreed.
It changes the picture. So it is very important for us to know that even though it is infiltrative, it is a low-grade glioma.
Agreed. I agree.
The second, everything else looks similar. Oligolet cells, calcification, those blood vessels. Especially if it's a small biopsy. Then it becomes.
The second thing which I had was you mentioned histone mutation can be seen in pilocytic too. If I'm not wrong, you made a statement like that.
Correct.
So how do you put them together then?
Then we don't give significance to the H3K27M mutation. We give importance to the pilocytic astrocytoma.
Meaning BRAF fusion. So they need to have BRAF fusion.
Even without it, we don't give importance. BRAF fusion we don't test for all the patients.
Pilocytic.
We don't test for all the patients of pilocytic astrocytoma. Radiologically also you would have said that it is not a diffuse midline glioma. Clinically it will not fit in. For us, histopathologically, we'll have a classic pilocytic astrocytoma picture. So we should not upgrade it from a grade 1 to grade 4 just because it shows H3K27M positivity. There are exceptions where even in a gangliogloma, in an ependymoma, you can see K27M mutation. So that is the current consensus, but there are few groups who believe that pilocytic astrocytoma, which show H3K27M mutation, they have a poorer prognosis when compared to pilos, which do not have H3K27M mutation, but they are not put into diffuse midline glioma. They do not fit in with the criteria of diffuse midline glioma.
Agreed, but so why do we do it?
Sometimes pilocytic astrocytoma, sometimes in the brainstem will not get a complete excision. We'll get a very small biopsy.
Okay.
If it is, for example, somebody sends me a biopsy which is very tiny from a brainstem.
Huh.
So I'm not very sure whether it is pilocytic astrocytoma or it is a diffuse midline glioma, unless I have a dialogue with the surgeon or the radiologist sending it to me.
Agreed. Okay.
So I want to rule out a diffuse midline glioma in that particular situation.
And you have already tested for BRAF fusion?
No, BRAF fusion cannot be tested by IHC. BRAF fusion, either you have to do FISH or you have to do RT-PCR. Both are molecular techniques which will require more time to do.
Okay.
What we generally do in a routine practice is we do our HND and we do our IHCs.
Okay.
So those are what, and forget about anybody at any center will generally have HND and IHC at there. Not everybody will have access to molecular techniques. So if somebody doesn't give importance to the histological features, even though there are rosenthal fibers, eosinophilic nanobodies, biphasic pattern, but just because it is in the brainstem, let's suppose somebody does an H3 IHC because it's there at their disposal and wrongly calls it diffuse midline glioma, which is grade 4, but the tumor is histologically, clinically, radiologically a pilocytic astrocytoma.
Okay. And a midline.
Yeah, but it is in a midline.
Midline. So that's why you would.
Yeah. So the confusion can arise.
Okay. Now again, for the clarity of the youngest ones who has joined the class, now tell me, do you do BRAF fusion as a protocol for pilocytics?
No, we don't do. It's not an essential criteria. Pilocytic astrocytoma is diagnosed based on histological features alone.
Yeah, suppose
we don't have to do BRAF fusion.
Yeah, I think
only if there is a small biopsy which does not have classical histological features, then we are in doubt. For example, you were in the beginning of our discussion, you were mentioning about optic pathway glioma. Sometimes you're not able to excise as much as we would require for us to see the typical picture. Then it will be a very tiny biopsy. In those cases, when we have a doubt, we do suggest or advise to do the BRAF fusion, but it is not essential to do BRAF fusion.
So what is the role? When do we do it? When
we do not see the classic histological features of pilocytic astrocytoma. That happens when our biopsy tissue is very tiny.
Yeah. So essentially, we don't need to do it.
We don't need to do it.
Yeah, but as I think in practical terms, that's an advantage of doing BRAF fusion because the inhibitors are coming into play.
BRAF V600, the mutation inhibitors are more into fusion or just entry.
Yeah, exactly. So there is a practical importance, but pathological importance might not be there. Okay. And the second thing is, you have never used a term pilomyxoid, isn't it? Which is always there. So,
pilomyxoid we do use. It is a variant of pilocytic astrocytoma. Earlier, it was considered a separate tumor type entity in itself. Pilo was given a grade 1 and pilomyxoid was given grade 2.
Agreed.
But now, so in 2016 classification, what they did not give it any grade because they felt there was some controversy regarding its grade 2 behavior. Now what they have done, because of its similarity in molecular alteration with pilocytic astrocytoma, it is just a histological variant, but both are grade 1. They are no longer different, but we do call tumors as pilomyxoid astrocytoma even now. The term exists.
It exists. Because I did not see a mention of it, so I was just wondering.
No, I have not dealt with circumscribed gliomas today. I have dealt with only diffuse gliomas.
Agreed. Yeah, I agree. Okay. I was just wondering. Okay. Thanks. Thanks. Naveen, you want to?
Naveen? No, I just yeah, Suhas.
Yeah, go ahead.
No, I just want to thank. I think it was a very good talk.
Extremely good session. Yeah.
Extremely. I think that we are getting good comments also. That it is really helpful for the residents. Also, they put in the comments also.
Yeah.
That's nice too.
Yeah.
Thank you, Dr. Shilpa.
Thank you.
I think
Thank you.
Yeah, we'll close the session. Dr. Megha and Dr. Shilpa, thank you very much again. I think the next session, I will ensure that the technical issues are sorted out. And both of you, thank you for joining on a weekend. Thanks a lot.
Thank you. Good night, everyone.
Yeah. And then the talk will be available in the YouTube session, so you can recommend it to anybody.
Sure.
Thanks, Shilpa.
Yeah.
Thank
you.
Thank you, Dr. Megha. Good night.
Thank you, Megha and Dr. Shilpa. Thank you. Good night.
Thank you. Thank you, dear doctors, for sharing your valuable insights. I hope you had a seamless experience. So with all your permission, we are signing off for today. And as we have no further questions, we are closing the session over here today. Good night and take care.